Okay, so we're now going to move on to the third and final use of the tool, how it facilitates knowledge transfer. So I'm going to go ask Cristina to come up, who's going to do a superb job of giving you an overview. But can I also ask then Morag, Francesca, Esteban, Lisa, and Zdenek just to come up and take a seat here, because we're going to follow with very quick, short presentations from each of them thereafter to describe their experience of the twinning. So just sit anywhere. And while they're getting seated, has anybody lost an iPad? Yes. There we go. Okay.
Okay.
Great. Okay, so on you go, Cristina.
So this second demo is focused on the aspect of knowledge transfer. Twinning and coaching, first of all, is the process by which you can either twin and coach a healthcare system to a good practice, which means that the healthcare system would learn what it needs to create in the local context in order to be able to adopt that good practice. Or it can happen between two healthcare systems. So one healthcare system learning from the other, which is more progressive in a priority dimension of integrated care, what it needs in order to also improve on that dimension. Knowledge transfer is central to twinning and coaching, and it was widely recognized as being an effective way of accessing evidence and learning on integrated care. The way we have developed the functionality of the tool for knowledge transfer followed quite an iterative process, and we started from the initial experience of 3 regions, Scirocco regions, and also we have involved partners in the discussion of how this should be implemented at each iteration. So, experts who have previously assessed the maturity of their healthcare system can use the Scirocco tool for the purpose of knowledge transfer through 3 steps. So first of all, they can visually compare the level of maturity, so now focusing on the twinning and coaching between a healthcare system and a good practice. They can visually compare the level of maturity of their healthcare system that they have assessed with the maturity needs of the good practice, which is viable for scaling up. Then they can select a candidate good practice for knowledge transfer, which automatically invites the organizers of that good practice to what we call a study visit. So in order to discuss what needs to be done in their healthcare system in order to make it possible to transfer over that good practice. Either during or after the study visit, the tool also facilitates a discussion on the features required. So what needs to be implemented, what needs to be changed, what needs to be added. How feasible these features are and how, what kind of adaptation is needed in order to transfer the good practice. I'm going to take each of the steps in turn. So first of all, visually comparing the healthcare system assessment with the assessment of good practices is done right, so starting right from the list of assessments that the experts have done. So they need to look at those good practices that have been shared with them, which they will see in the category of consensus good practice assessments. And then they can just select that good practice that they want to try to transfer. So for example, here I will be focusing on the one on the bottom, so consensus Norrbotten, a demo. They can click transfer, which takes them to the page on the bottom of the screen. So where this good practice assessment has been matched with their healthcare system Basque Country assessment. In case they have several healthcare system assessments, this would be rare being involved in several healthcare systems, but who knows, then several matches would appear here. So then they can just click on the link for this match in order to see how the different, so the diagram of the good practice would match with the diagram of their healthcare system. And if they decide to go ahead with knowledge transfer with that good practice, they can invite the owner of the good practice for twinning and coaching by just going back to the previous page and clicking on that invite button. This automatically gives you a confirmation on the page, but also sends both you as a user a confirmation that you have invited that good practice for twinning and coaching, but also the owner of the good practice an invitation to participate to a twinning and coaching study visit. Then during or after the study visit, as an organizer, you can go to twinning and coaching in the tool. And here in the good practice to healthcare system column, you can see on the bottom here the match between your healthcare system assessment and the good practice assessment that you've just invited as having been created, having been set up as a meeting. And you can just open up that meeting and you will again see how your diagrams were laying on top of one another. And during or after the meeting, you can write features, whether they've already been partially implemented, how feasible they are, what adaptation will need to take place in your healthcare system in order to be able to adopt the good practice. The second case, twinning and coaching between two healthcare systems, the process is similar with one important difference in that you need to first set up a priority dimension. So as I said, the knowledge transfer between two healthcare systems means that you want to find another healthcare system which does better on a certain priority dimension in order to learn from them. So you need to first of all set up this priority dimension on the tool. The rest of the steps are similar. The difference is that you start from your own healthcare system and you look at matching healthcare systems, and this time they are matched depending on those that do better on that priority dimension. And the rest of the steps are similar. What is compulsory for you as opposed to the previous case is that you need to at least provide the features in the twinning and coaching meeting, at least the features for that priority dimension. So to record the priority dimension, you can just edit your consensus healthcare system assessment. You can go to the dimension that you want to make priority, and at the bottom of the screen here, you have a radio button which you can tick, and it will automatically make that dimension also show on the spider diagram as being a priority. Then, to start the twinning and coaching, you can go to consensus, so just the list of assessments, and under consensus assessments, healthcare system assessments this time, you can retrieve your healthcare system assessment and click twin. This will lead you to the list of matches. You can open any in the list and see them, how they are compared. You can go back and invite them for twinning and coaching if you decide that they are the ones you want to learn from. This gives you a confirmation and again sends 2 emails to yourself and to the organizer of the healthcare system in order to invite them for a study visit. And finally, during the study visit, this time from twinning and coaching healthcare system to healthcare system assessment, the match between the two has been saved as a meeting. You can open it up. You can see how they compared, and you can enter features as I said before. The difference being that it's compulsory to do it for the priority dimensions. For the rest, it's optional. While for the healthcare system to the good practice one, it's advisable to do it for all of them. Okay, the outcomes of twinning and coaching will also be captured in the form of action plans. However, the implementation of the action plans is not considered to be the scope of this current project. So the idea is that the action plans make recommendations or agree actions for modifying the measures or interventions to be taken, inform decision makers about priority actions necessary for the adoption of a particular good practice and the improvement of a specific aspects of integrated care. And this is about it. Thank you very much.
Thank you, Cristina. So if that was all as clear as mud, no disrespect, Cristina, that's a lot of information to take in and lots of clicking and going back and forward. So what we're now going to do is demonstrate, or not demonstrate, but tell you the story of 3 twinning and coaching, well, certainly from regions, three regions' experience of twinning and coaching. So first of all, we're going to kick off with Francesca, who's going to set the scene for twinning and coaching of Scotland and Olomouc with Puglia.
So good morning, everybody. Well, during the process of twinning and coaching, we were very glad to find out that 2 regions were interested in one good practice that has been going on for quite a while in Puglia. And so the first twinning and coaching happened between the regional context and a good practice. 2 regions that, namely Scotland and Olomouc region, were interested in learning about our good practice, that is about telemonitoring, teleconsultation and telecare project for patients with heart failure, COPD, diabetes in Puglia. Basically, what is this about? Basically, it's about the remote monitoring of elderly and complex, very complex patients that are still bedridden, but stabilized. So their lifestyle improves really in an important way because they can be looked after at home thanks to a special device which consists in a bedside table equipped with remote monitoring of vital parameters. I'm not going to go in deep to that, but basically it keeps patients out of hospital even if they are in a are very frail and in difficult conditions, which is of course an advantage in terms of other advantages in hospitalization. What really took to implement in our context and to succeed with this good practice was a change of approach in managing frail chronic patient. I can't really, well, it's not working. Anyway, change of approach in managing chronic patients. The other thing was to have a full integration between hospital and primary care, because you need, of course, a direct contact just to take charge of patients when they are just out of hospital and keep on continuing in a continuity of care to look after them at home. And finally, just some routine. There wasn't really a big change in the routine of our professionals that need to be trained, but didn't need very much to learn or to change in their organization, which is really the success of this good practice that took off very quickly without very much investment. I leave now the word to Scotland, I think. To give their perspective about the experience of this twinning and coaching in Puglia, where we were the coach and they were the receiver.
Thank you. Good afternoon. My name is Morag. I'm from Scotland, NHS Lanarkshire, and I was privileged to take part in this twinning with Puglia, and I just say thank you very much for the hospitality and the wealth of information that we received. The rationale from our point of view was really we had identified similar issues and ambitions to assist people to be cared for at home or as near as home as possible. That resonated very strongly with us in Lanarkshire and indeed in Scotland. It actually fits with our national outcomes for older people in general. We wanted to identify areas of good practice that we could then prioritise in our own action plan, and I think this is what we tried to do very successfully on the visit, which I think we're going to take forward. We had the local conditions for the adoption of learning, and you can see there were some similarities there, and there were some areas where absolutely they were far better equipped than we were on the time. And we looked at the feasibility where we could take things forward. So, for example, it's already been spoken today about standardisation and simplification. That's possible for us, but with a significant amount of effort. But there's plans already in place, as Margaret and Stuart have already alluded to, around a citizen portal, which we don't have at the moment. We're trying to ensure interoperability is a key standard with any new systems for procurement. And that's something that we really valued when we were in Puglia, how they had already managed to do that. We haven't got that. That's something we would aspire to. What wasn't feasible, although we were hugely interested in their local industry being fully involved in the development of the bedside table and this equipment that went into the patient's home and indeed into the community hospital base, that would make it very difficult for us. It's not something we could translate easily into Scotland because we've got rigorous procurement and financial policies and procedures and frameworks that we have to adhere to. And we've also had previous issues with platforms that we're unable to then support at scale. And we're trying to achieve a Once for Scotland mantra really around what we're doing is once for Scotland and not simply what we've got at the moment, where Margaret's already said different platforms, different systems, nothing really links up particularly well with each other, and certainly not between health and social care, which is where we need to go. Our priority actions we took from the twinning visit was certainly to improve the citizen empowerment. Enabling truly integrated care requires an increase in public awareness and engagement. And you will have seen from Margaret's spider from Scotland that, yes, we might think we're doing quite well, but maybe our citizens don't think we're doing as well as we should be. And as she said, we need to be listening to what they really want to get out of this. Evaluation, I had the conversation earlier. If we get the systems integrated, if we get our data right and value and proper, then that will then allow us to evaluate more effectively. I think there's an awful lot we could do there. So absolutely, that's what we think. And finally, my take-home message was very much, if you have the opportunity, take it. The twinning visit was absolutely wonderful. It really made us open our minds to how we could take this practice and make it work in Scotland, or what wasn't. It was absolutely useful to have that wide representation of clinicians, operational staff, and strategic managers at both a local and a national level. And that then let us talk at that level to people in Puglia, which was really, very, very welcome. I have to say, the generosity of our twinning region in Puglia about sharing their information freely across all of their stakeholders. They shared that good practice, and I think what I took from this was really the fact that it's not just about what's good practice, it's about the journey to get to that good practice, and that was where the twinning visit and actually being on the ground really helped us. So thank you very much, and thank you again, Puglia.
Thank you.
Excellent. Thank you very much, Morag. So that was one example of twinning. We're now going to move on to the next one, which it's Zdenek. Zdenek, this is a recurring theme, isn't it? I did that the last time. So sorry, we're going to hear about the other part of that twinning with Puglia from the Czech Republic. I do apologize.
Good afternoon. I'm here again. Yes, so we were together with the Scottish delegation in Puglia, and it was not a random choice that we went to Puglia to see about details about the good practice, because we have similar good practice focused on improvement of care of cardiacs when they are at home. That means this good practice of Olomouc Hospital is also located in the EIP database. It can be found. And we looked constantly for extending how to extend the scope of the good practice. And this Puglia example was very good. Gave us lots of instruction or inspirations how to improve our good practice and how to progress in increasing quality and effectiveness of care of chronically ill patients, particularly cardiacs in our country. The local conditions for adaptations of the good practice are not excellent, obviously. This is given by the reasons I spoke about in the morning, but also we must stress the differences between the healthcare systems as such, the insurance-based system. I just remind that insurance-based systems is the consequence is that each activity in the care process must be somehow listed. And then it's performed by the doctor or by the nurse, and there's reimbursement for such activity. That means if there is nothing listed, the nurse and the doctor are just not doing it because they are not paid for that. That means this is an essential barrier in any change in the care process. But if we look inside of the good practice and the assessment of the healthcare system and the conditions, how the good practice was actually developed, we found that the population approach is very similar. It's almost the same. I don't know whether Francesca stressed this. The good practice in Puglia was designed by doctors. The core of the activities, the details were designed by doctors. It's exactly what we are doing in our country. We are developing the good practices together with doctors, and then there is the additional layer, that means the administration, organization, and other things which are absolutely necessary, and financing, but the core of the good practice is designed by doctors. And the same approach is in population approach. That means how to stratify patients, and it's also driven in my country, as in Italy, by the medical community. We call them medical community. It's not driven by any authority, for example, by regional authority or by ministry. It's driven by medical community, by the staff in the hospital, in the healthcare, on the side of healthcare provider. But the other dimensions are really different, in not only in the score, but also in features and other aspects. We may look at it, and this means that the good practice as such cannot be transferred just simply, even if we manage some kind of improvement in the score of various dimensions. We cannot say, oh, this is the best condition, and now we can start with the good practice the next day. So we need some reforms to be able to adapt the system for innovations like moving the patients to home and support them at home, and also have the financial model, sustainability model for such kind of service. So this is why we are actually working on innovations in our e-health center in University Hospital in Olomouc. So we close with the ministry and with other stakeholders design or participate in design of various changes or proposals for changes and even reforms of the system to be able to introduce such innovations. One of the activities mentioned in this middle part, that means the use of structural funds, which is the activity I spoke about in the morning. And also we need to do pilot projects first. Maybe if pilot project is not well known or not welcome in the approach of regions as such, that means regions like to do things regularly. It's already too complicated to organize pilot. It's better to do things. But in our healthcare system, it's difficult to change without huge administration support. That means to have really functioning financial models and other things without proving that the new intervention functions. So we opt for pilot projects first. At the moment, it's no other way how to demonstrate the effectiveness and the usefulness of the new good practice or new innovation actually introduced in the care process, rather than just use a pilot project and do it in small scale somewhere. For Olomouc as such, so this is on the level of the state, and on the level of Olomouc, that means in region, we are preparing currently several new interventions which can grow in the future in good practices, relate to support, they all relate to support of patients at home in various medical disciplines like diabetes and other negotiate with all three key groups of stakeholders. I repeat, it's a state as a regulator, insurances, we have several insurances, and also healthcare providers of diverse ownerships. And this is what we are regularly doing. That means meeting with these stakeholders and negotiate the improvements to be able to introduce the good practice. There were lots of learnings in the good practice. I calculated 24 key messages, actually. 24 key messages, quite a lot. Starting from finance, going through also the medical design, you know, how it can be done from somewhere from inside of the clinic, and suddenly it's really good practice which can be assumed by the region as really nice example of what can be done. So approach to care integration, innovation development, how it can be done, how structure funds can be used actually, because this is good practice was also born thanks to structure funds. So this is also piece of innovations for us. It never happened before that an improvement of care in the care process was demonstrated thanks to structure funds in my country. So it is piece of news, and obviously financing and some details, you know, how to use video conference. We were surprised that electronic health record is regularly used by the staff. So it's something we still don't have in my country. So it was really interesting to see all the details and also the actors, whereas, you know, technicians, doctors, managers, all the people were able to talk about the good practice and told us all the details which are really useful for our good practices which we are designing in our e-health center in Olomouc. So thank you.
Thank you, Zdeněk, and apologies again for that oversight. Okay, so we're now moving on to Andrea, who's going to very quickly introduce the next set of twinning, and will then be followed by Esteban and Francesca giving their experience.
Yeah, so just very briefly from the perspective of transferring regions. So this is again the type of the twinning and coaching where we had two receiving regions. So basically twinning and coaching doesn't always need to happen just between one region and the other region. So here we had, as Donna was saying, Basque Country and Puglia as the receiving region and Scotland transferring region. And the focus of our twinning was around the engagement of the third sector in the provision of integrated care. So just very briefly on the outcomes of our assessment. So by applying the maturity, by applying the Scirocco tool and what kind of features we consider for the purpose of twinning and coaching. Just a bit of background before I highlight those features. The third sector in Scotland is really quite big. We have, just in terms of the size, we have over 40,000 registered organizations. This can be, as Margaret was saying, the more non-governmental, non-profit organization, charities, social enterprises, and all these different and any others. Their financial turnaround is over £5 million a year. They provide 69% of our social services, so that's just in terms of kind of like the size of the sector. There's also really a strong framework for the coordination and alignment of these activities. So we have 5 strong national umbrella organizations representing all of these third sector organizations to make sure that we are fully aligned to the national ambitions. And then, as was pointed out by Margaret in the morning, there is a legislation act in place which brings together health and social care and also gives basically, again, the legal framework for the engagement of the third sector organizations as well. So as a result of the legislation, we have created those new joint boards, and the third sector is represented on those boards. So third sector is directly involved in the planning and commissioning of the services. There's a lot of dialogue, a lot of partnership building, partnership approach to the care delivery, and I would say that the last feature which I would like to highlight and which was very much discussed during the twinning and coaching was the fact that actually the quality of these services provided by the third sector is overseen by the care inspectorate. So that comes to that high requirements in terms of the evaluation methods And I won't drill on the breadth of ambition because you've heard earlier from Margaret that we basically are aiming for that full health and social care integration, including the engagement of the third sector as an equal partner in the delivery of integrated care. So I now pass to first of the receiving region, to Basque Country.
Thank you, Andrea. Yeah, so the third sector exists in the Basque Country too. It's composed of different kind of organizations of different kinds, voluntary, NGOs, and so on and so forth. There is more than 3,500 organizations with more than 125,000 volunteers and 36 employees from these organizations. So we have this organization with quite a big annual turnover in economic terms, and there is some kind of responsible department in the government, the Ministry of Employment and Social Policies, that is who takes care that everything is running smoothly. However, the problem that's arising now in the Basque Country last, let's say, 10, 15, 20 years is that in a society where traditionally it's the family, as in other European southern countries happens, that the ones that are taking care of dependent relatives or people, well, things are changing. Women are much more who were traditionally the ones that were taking care of these people are getting into the labor market. The economic crisis has become a real stress on the family life, and well, the problem is that even if the health sector and the social services sector, as Igor said earlier this morning, are starting to cooperate, there is hardly any kind of engagement of the third sector, the voluntary sector, in any kind of healthcare-related activities. So one of our challenges in the Basque Country was, or still is, how to further engage these kind of organizations in some of the activities that are related to integrated care. So we found out that in Scotland, they have a long tradition of engaging the third sector on these kind of things. And well, we thought that we could learn a lot of things of their experience. They have a strong third sector, so when it comes to choose one of the good practices or one of the perspective or characteristics of the system that we would benefit of in all our partners, we thought that this one could be a good choice. So when it comes to the analysis using the spider diagram, the yellow line is the Scottish maturity requirements for the third sector involvement in integrated care, and the blue one are the maturity of the Basque healthcare system for integrated care. You can see that, as Igor said before, we have a more or less homogeneous scoring in all dimensions, but there was one specific aspect that we wanted to study further, study more in depth, which is the evaluation methods, which was one of the characteristics that seemed to be very different than the others. It looked as if we were prepared to transfer this perspective. So looking at the features, what we found that one of the features that we could transfer, or at least learn from it, was one of the ones that Andrea has just mentioned, and this the existence of our care inspectorate that evaluates, assesses, monitors the care provided by these voluntary organizations and so on and so forth. So that was one of the features identified that could be transferred or at least analyzed further by our group, whereas there were other features identified in the maturity requirement of the Scottish experience that we found that were not possible to be transferred. For example, Scots have a long tradition, and Margaret said that before earlier this morning too, of legislation integrating social and healthcare. And this is not the case in the Basque Country, and we do not foresee in the next future that this will happen, because social services are run by different administration, local authorities, provincial authorities, and so forth. So we think that this feature will not be able to be implemented in our case. So after this analysis, we identified some priority actions so that we could enable the adoption of the engagement of the third sector in Basque Country, and the idea in our action plan to develop those activities is to set up a group with representatives from the three sectors, health and social sectors, but also the third sectors, and work on the evaluation dimension and trying to identify a set of indicators that could be included in our framework contract for integrated care, and try to include some kind of indicators so as to evaluate the engagement also in the evaluation framework of the each of the integrated care organizations. So this is what we want to take away, and our messages to bring home is that the team that was visiting the Scots, and we are very grateful by the hospitality of the Scots with our team, is that we have learned a lot. We have really seen the real challenges and the realistic developments that can be achieved in a region with such a long tradition as Scotland. And the use of the Scirocco tool in all this exercise was a catalyst to understand better and to reach agreements on what were the priority actions that we should try to take back home in the Basque Country. So that's all. Thank you.
Thank you.
Well, here I am again. I'm going to talk about Puglia now. The reason why we decided to the reason why we decided to go to Scotland, because we actually were we got really interested in one good practice that they carried out in the region. And because basically in Puglia, as my director said before, we are working and we are struggling with the challenge of aging population, and we working really hard to implement an efficient and effective integrated model to look after our chronic patients and elderly. But there is one thing that still remains a challenge in Puglia, and actually is the integration, the horizontal integration, so integration with social service. Actually, there were many. They have been carried out a few attempts to try to experiment integration between the two sectors. Most of them were in the area of the independent living, so more disability than frailty and elderly. But still, that we needed to understand what was really the obstacle, what was the barrier that wouldn't let us take off from that point of view, because we've been working hard for a very long time in these last few years. So we were really interested. We knew that we had a problem with the third sector, but actually we needed to understand better. So we went along the good practice and the assessment of the third sector, the requirement of the third sector carried out by Scotland, and that we realized that what really makes the difference and can make the change is the culture, first of all, so the approach, the cultural approach, the need of a very, very robust regulatory framework which exists in terms of organization and providing and delivery healthcare service and integrated service, but not in terms of integration between social and health care services. So you need really to have to strengthen the structural governance according to the dimension of the spider diagram of the Scirocco tool. And and we do aim for full integration of services, and the self-direct support service can become a real thing if we manage to share protocols, meaning that if we share also the way to look after and to take care of our patients, that would certainly facilitate the integration of services, because in this case you basically have a real view of what are the real needs of the patient. So if we talk about, I really like to touch all the dimensions, because this is what we did going through our action plan, because we want to make it realistic. So we had few commonalities. This is the two diagrams overlapping. The yellow one is the assessment, the Scotland assessment, and the blue one is Puglia. So there are many differences, but few commonalities. Commonalities is in capacity building, innovation management, and e-health that needs a few adjustments. So I would say not relevant for the specific adoption of this good practice, but still can adjust just to fit the purpose of our objective. What it really needs a change is structure and governance, because we need to increase, and I said, to improve, to strengthen the legislation in terms of integration of services. Regarding the differences, there are a lot of differences. As you can see, we're a bit different from Basque Country. So we're talking about readiness to change, population approach, citizen empowerment, and my director talked about this before, evaluation methods and breadth of ambition. As I read, I wrote underneath feasible to transfer with adaptation, because the difference we have, we're not that big. It's just need to be focused, and this is where the tool helped, to specific purposes in order to succeed in integration. Actually, dimension 4 was meaning standardization and simplification, because we have a complete different system for collecting data and standardization of processes, digital processes. So from that point of view, probably there won't be any possibility, but a different methodology to reach the same objective, and we would work on that a bit more. Oh, sorry. So strength, finance and funding. Actually, we realized with our stakeholders that the system, finance and funding system, was quite strong. So we used a lot of ESF, and that worked really well. Removal of inhibitors, well, if we act on the other dimension, the removal of inhibitors would come without saying, because the inhibitors are exactly the thing I said before. So the cultural problems, the legislation, and those are the things that doesn't make it possible to take off a full integration in Puglia. So I want to share, this is very, very big, but what is important for us is that this is the action plan, what it should look like. So you have the priority action you want to propose to your policymaker, the objective of the action, the anticipated outcomes, and the policy implication, and including who is going to do and why and how. In our case, we need a reform of the third sector, certainly, because, as Esteban said before, in Scotland there is quite advanced, and there is an historical, an historical organization of the third sector, very strong, very powerful, and we were very, very interested on that, and it was really, something to get quite a lot out of in terms of experience, and certainly embed third sector in our organization. Integration of funding the system, this is very important. If we want to get to the point of integration of services, we need to achieve the integration of funding, to have a co-payment of the delivery of care, of health and social care, which is something that can be possible. We had few experiences, few pilots from that point of view that are very similar to the CARGOM experience that we went to see in Scotland, but still we need to have it systemic, not just piloting. As my director said before, there are a lot of things going on, but we need to work further to scale up what it really worked in our country. And then improved data collection. So we need to integrate data, because only integrating data we can build health and care pathways that includes social needs, and co-funding will feed, the delivery, and will really make the solution of all our problems. So extension of pilots in terms of anticipating the result. A more effective distribution of resources is something that can be done, and we discussed with the social service, and is possible. Better management of citizen needs, and this was what my boss anticipated before, and reduction of inappropriate use of health and social care services, which would be a lot. The regional agency I work for and my director represented is responsible for introducing innovation processes. So we are directly involved in this, and we are very interested in the idea of doing it. And in this case, it would be nice to have to sign probably a memorandum of understanding with Scotland and learn more, being having coach and support us in this track towards succeeding finally with our integration. Well, take-home messages help us, of course, to focus on specific issues. So if we finally understand, thanks to the tool, what was missing for us to get to full integration of services. And if you concentrate on one dimension, it makes you reflect also on how all the other dimensions are connected. So where you have to intervene again in order to succeed in what you want to reach, as I said before. Improved awareness of the situation in our region, and it was reassurance because we find out that we're not that far to reach the target. We are on the right direction. What we're doing is correct. We only need to believe more in it and actually test the new system. The other good thing about this is that I realized during the site visits as a coach and as a receiver that these site visits work bilaterally. So we learn and we give, and during the site visit, you give and you get. So you learn something, but also you receive things, and not necessarily aspects of the system of the objective you aim to reach in that very moment, that site visit. But you do learn a lot, and it goes a lot beyond the objective of the site visit very often, thanks also to the discussion with the tool. And then, last but not least, for the first time, the health sector sat on the same table with the social sector, and we could work together and think together what it wasn't working and why. And this, for us, it was the greatest advantage of all, to my opinion, but on evidence-based outcomes. That was thanks to the tool that we could discuss on that, not point of view, but really perspective, different perspectives towards the same objective. Thank you. That's all.
Thank you, Francesca. So we're now moving on to the last example of twinning and coaching before our coffee break. And I think here we are going to be introduced by Stuart initially for the receiving region. Lisa, and then then you.
Would you look at that?
So Stuart's going to introduce.
Hang out with you.
Yeah, I'll hang out.
Yeah, just hang out. You look good together.
Yeah. So we're the ones standing between everyone and coffee.
Coffee, yeah, I know, it's terrible. Okay, so I'm going to talk a little bit about twinning and coaching in Scotland. Yeah, okay, so type of twinning and coaching. So it's looking at transferability of learning related to particular dimensions. So there'll be the tool has a priority dimension that you can pick out and say, this is the main thing. And the role of the regions in twinning and coaching. So here, looking at Norbotten here will be the receiving region. Scotland is the transferring region. And the focus that we're looking at is innovation management in Scotland. Yeah, so, and I think now I can hand over to Lisa. Yeah, and here we are. Yeah.
Fantastic, that sounds about right.
Stuart, that's your one too.
Oh,
Yeah, there you go.
Oh, I didn't know that. I only had one.
Enjoy.
Okay.
Work today very hard.
But yeah, today it's hard work. So, so here we have the the focus dimension here is innovation management, yeah, and here is looking and saying, is there a formalized innovation management process? So here, this is the feature that we're looking at. So it's planned and partially implemented, and there are good examples of systematic innovation in place. So if we look in Scotland, we have things like the Digital Health Institute, which actually looks at doing innovation, yeah, and and actually links here along this dimension. And we actually do have these things. And this is one of the features that have been identified. And then the innovation landscape is quite well developed in Scotland. We've already got quite a lot of innovation champions and elements in the Scottish environment which actually support innovation. And then the existence of the innovation centres and networks actually formalise and embed innovation. So we actually have a structure that allows some learning across the different sectors. So if you look, we've had this systematic approach to introducing innovation centres. Some of them, the digital health one is specifically in health sector, but we also have, say, a construction one, which actually has got quite a strong interaction with the health one, because now we're looking at actually what can we do in terms of built environment around these things. So there's linkage and transfer of experience between those things actually happening in the innovation centres, and those are developing and going forward and entering, I think they must be about the 5th year of their progress. So we have these features in the Scottish innovation environment that I think are of interest to Norbotten.
Thank you.
And now here we have the Norbotten section.
You sure you don't want to come back?
No, yeah, I'll stick around, Lisa.
Yeah. All right, so in comparison, this might actually be quite interesting to those of you who know where Sweden in general places on the innovation scoreboard. Do you know that? We're number 1. We're Europe's innovation leader. Our region even is innovation leader in Europe, one of the innovation leaders. But not necessarily in terms of innovation management in integrated care, I would say. So that's sort of also the rationale for this. And our low scoring and what sort of, let's put it this way, one thing that we actually wanted to twin and be coached on was evaluation methods, but nobody really wanted to do that. None of us regions wanted to do that. I think we want to really find a region who's good at that, let's put it that way. But basically, the lower scoring that we have is because we do capture innovation. Absolutely, of course we do. And there are some mechanisms in place in order to encourage knowledge transfer. And I think encourage is really what we can focus on here, because it doesn't mean it's being done. So we do have some mechanisms in place. Formalized systematic process, no. Not across, I would say, if you would look at an innovation process as such. We also have certain functions that we have established, but it's that systematic approach that is missing, actually. And then when we're looking at the implementation of innovation, and also a big part of it when it comes to reimbursement and procurement, for an example, those things are completely detached from the innovation process today. And it's a big part, if you're going to be quite mature within innovation management, that those parts at the end do need to be also, it needs to be part of your systematic approach, which we do not have today. So, and when we were comparing and looking at the different features and what's feasible and not really feasible for transfer in terms of what we have as our local conditions, as you can see, that blue little figure here on in the diagram, if you can see, that's the assessment of our healthcare system in Norbotten. And where you can see then the difference in innovation management. And then when we looked at different features, one that we saw was quite feasible for transfer was, oh, I see it has moved a little bit. It's the readiness for change. And I mean, it's easily, we had the same scoring, and that's also based upon that there is a recognized need for innovation in both systems. And there's definitely a recognized need for innovation in our system today. We've just started a journey where we have created a new vision for the transformation of our healthcare system. It's called Vision 2035. So we do have quite a good view of the readiness to change. There is a certain alignment of stakeholders and projects, I would say. in order to be able to deliver on that same vision. And there is quite a broad acceptance. And I think that is visible also, of course, in the Scottish system. And that was something that we could see, well, there isn't much that really needs to change. We're quite there. But then when it comes to the structure and governance, both for innovation and collaboration, and also supported by dedicated funding, what we see is that we would require some adaptation there, and especially in terms of innovation funding. And not just funding, but a clear roadmap, because that was something that we saw in Scotland, a clear roadmap, and we really do not have that yet. So that is something that we would need to be working on. Some priority actions for us, and these are kind of almost like hygienic factors for us, or prerequisites in a sense. Data sharing is really, really, really important for us. Because we have challenges when it comes to healthcare and social care related data. And for us, in terms of having proper innovation management and for integrated health and social care, where we actually want to be, we really need to work on data sharing and platforms for data sharing. Roles in innovation management and mandates. Again, something that's missing. We have certain functions in place, as I said, but roles and mandates are not distributed evenly. If you would like map out an innovation process. So that really is something to be worked on as well as roadmap and funding, as I was saying earlier. Some take-home messages for us from this twinning and coaching was really that what we liked about using the tool as such was it does provide a structure and a more focused visit and learning, because you're also focusing your discussion. Because we've conducted some certain, well, of course, study visits before based upon interest and maybe learning and twinning and coaching sessions, but they have never been as focused. So here you're really actually focusing on what you're there for. You're not drifting away in some other topics. And also, when you start to drill down in one specific dimension that you know that you might have a lower maturity in, and when you're starting to get down to the specifics and you start to analyze it, it actually creates a sense of urgency, which is quite nice because it promotes certain steps towards the change that you need to take that otherwise could feel like they're a bit too heavy at the moment. But another take-home message, and I think Zdenek was actually talking about that, the setup of different healthcare systems. You always need to understand the difference between certain healthcare systems. Is it a national healthcare system in comparison to a regional healthcare system? What's legislation like? How is healthcare and social care divided up? How is it financed and so forth? So it's something you always need to reflect upon, I would say, no matter what you're trying to transfer and what kind of learning you're sharing. That's it from us. Thank you.
Thank you, Lisa.
Coffee break.
We almost have a coffee break, yeah. So just before we break for our last coffee break of the day, I'll open the floor to some questions. But before I do that, one of the things that we set out to do with the Scirocco project was to determine whether or not the Scirocco tool could actually be applied to the assessment of the maturity requirements for good practices. So I'm just going to ask you, each of you quickly, to kind of say, do you honestly believe, and you're allowed to say, even though you are a Scirocco project partner, you are allowed to say negative things. Do you think that the Scirocco tool did add value to that twinning and coaching knowledge transfer experience? So Esteban.
Yeah. Well, I would have loved to have Lisa's last slide, and I would just say exactly what she said.
We could have it up again if you want.
Yeah, I think it states very clearly what is the use of the Scirocco tool in this tuning and coaching exercise. So I think the value that the Scirocco tool adds is not the same in the different use that we have been testing in the project, but it is also helpful in the knowledge transfer exercise that the twinning process has. Yes, so I would say yes, but in a different way that other uses.
Great, thank you, Esteban. Lisa, well, you've kind of said it there.
Yeah, what he said.
Yeah, which is what you said. Morag? Morag?
At the risk of duplicating it, that was exactly what I was going to say as well. I think amongst us we've probably identified a number of different ways that has been useful for visits, and definitely it gives that structure. So yeah, I would agree, definitely.
Thank you. Francesca?
Well, I said that already as well. I said that helps supports a lot to focus on specific issues. And in Italy, we have this ability to talk when you have a meeting, have a brainstorm, and you never get to the end of it. With a thing like this, I think it's very important that it gets your attention on one problem and makes you reflect on what you want and go, as Lisa said, go deeper and deeper and realize that you need to work on that specific issues if you want to change something. So orient and focus is definitely orients the discussion.
Great, thank you. And Zdenek, last word to you.
Yeah, similarly like Esteban, the tool is very useful as an additional instrument when you are doing changes or scaling up good practices, for example, from one region to another one. But it's not a standalone tool. Just on one side is one region with its good practice, and on the other side is, for example, our region, and just to use the tool, and that's it. That's not working. So it's additional tool. It's excellent because you learn or you realize more things when you have the tool on the table or on the screen, and you see many more things than you might have considered without the tool.
Excellent, thank you very much. So, any questions for our panel on the experiences? Yes, we have one here. This lady here first, and then we'll come to Mark. Can you just say who you are and where you're from?
Yeah, Lena Otto from Dresden Technical University. I just have a question because in the panel before we heard that everyone asked different local experts. Some involved the citizens, some didn't. Did you experience in the with the coaching that there was a problem that everyone asked someone else, or was it a good database even if someone else was asked?
I can answer. Well, in our experience, both in receiving or transferring, we didn't experience this problem. I mean, one thing that you have to do, if I understood it right, one thing that we had to do is to choose the right people, the right expert. You know, because if you go for a training and coaching session, you've got to make sure that you have with you the right people that can give the right answer. But if this doesn't happen, I mean, training and coaching, it doesn't happen only in that session. There is, after that, a continuation till you write your action plan. And if you need to go, deeper, further, in the explanation, or you can always have another session. I mean, during the project, we didn't have time for that. But what I really wanted to say before as well, we've got to keep in mind that the assessment tool itself is dynamic. So when we have a picture of what is happening now, it could be, changing in a certain time. So it's an evaluation tool. It can change very quickly if the situation, and that is what makes the difference, because we notice that in our region, our context is already different. We know that from when it was before. So it's dynamic and very flexible. So I don't see a problem in that personally.
Thank you. I think Mark, and did you want to? Yeah, we've also got one from Stuart. So, yeah, Mark.
Thank you, Donna. The take-home message from the receiving regions are very clear. What about take-home messages, or what about the learnings from the transferring region? And what is the incentive transferring regions have in welcoming study visits and in putting in place such a methodology, such an organization for the study visit?
Good question, Mark. So, well, Scotland actually might be a good place to start.
You didn't pay attention to everything I said. But I give you that.
So, from a Puglia perspective?
No, from a Puglia perspective, I say that is, as I said before, whether you are a receiving region or a transferring region, the learning is bilateral. So I found myself in the situation in which I went to Scotland to look for other things, but I was asked about something that was happening in Puglia. And when they came over to Puglia to look after something, they, we learned, because we were the coach in that situation, we learned about a lot of other things that were happening that were different, but could be interesting as well, that we didn't keep into consideration.
You learn for yourself, you mean?
For my regional perspective, not myself. You learn, you transfer something, but while you are transferring, because the process is bilateral, you talk about your issues, your problems at home. At the same time, you find things that could be interesting for you, even if you didn't have that in mind. Just listening to somebody else, stakeholders, the same level from another country, and then talking to each other, you learn of other things that were not necessarily the objective of the twinning and coaching. This is my experience.
I think, just before we'll ask Margaret to speak on behalf of Scotland as a receiving region, but certainly some of the feedback that we've had is that for the receiving region, it really does help them to raise the profile of their good practice at levels where it possibly would not have gone. Sorry, transferring, yeah. We're getting to the end of the day. The transferring region. So certainly I think your colleagues in Puglia said that, Francesca, that actually it raised the profile of their good practice at levels that it might not have been so, looked at out with their own area. So that's a really important thing, that it kind of almost gives you a kind of acknowledgement of the fact that all that effort and hard work you've put in is actually recognised as being something that's of value and good work. So there's a positive point. Margaret, do you want to add anything from Scotland as a
probably not a lot. I think the benefits that Francesca's identified for both the transferor and the receiver, I would absolutely concur with, because I think when you're stepping slightly out of your own familiar environment, even to tell others, you're getting a bit of that helicopter view, and it's maybe validating some aspects of strengths that you might have taken for granted, but I think it also just allows that sort of check and balance. So for me, I think both are equally important, and I do agree with Donna. Sometimes highlighting something is good for a region because it gets some recognition, and I think people know that you beaver away, you're often doing excellent work, but sometimes never a profit in your own land, and I think being able to evidence that others are coming over to learn and to hear about what's happening in your region, I think is helpful for the policymakers and planners, etc. But I think both, to me, and certainly what I've heard this afternoon just reinforces that it's very much about this bilateral approach about the learning, receiving, and by transferring you're also learning. So I think it's that iterative approach.
Thanks, Margaret. So we've got one question from Stuart. Any last questions before we break for coffee? No, so Stuart, last one to you.
I just want to pick up on something that Lisa said, which was just to ask all the panelists what they think about evaluation. And do you actually think it seems like perhaps there's an opportunity for a European intervention in the evaluation of complex integrated care settings?
Ooh, there's a challenge. Does anyone want that?
It's a challenge.
Yeah, it's a challenge. I agree. But one thing, very important, as one of the takeaway messages here, is that the Scirocco tool is not an evaluation tool.
No.
To compare good practices, countries, and whatever. So, just to make it clear, this is not an evaluation.
Exchange evaluation experience, but it seems to be there.
Okay.
Nobody was there to do that.
Yeah. No. I think that requires a whole project to study. What is evaluation? How do we evaluate? So I only leave the message that the tool is not for evaluation.
Great. Okay, so we're going to break for coffee and then go into the last session. So 20 minutes break.